Welcome to the Mindset Mirror Connection podcast. In today's episode, we are talking to Dr. Leigh Lewis, a certified menopause specialist. You guys will not want to miss this. I know you had a lot of questions when we put it on our Q&A. So if you're ready, listen up and lean in as we elevate your minds.
Woohoo! Okay,
Yay!
So how we all got connected is, so Dr. Leigh Lewis and I have been in connection since I started the training in Phoenix area, and you were one of my first contacts and very open to discussing with me. So she's in my referral network for my clients that I see in person and then some virtuals that I've had. And what we love about you, and I've shared your page with Christina, and then that's how us three got connected, is because your take on menopause and women's health is so cut and dry. There is, as we've talked about many times on the podcast before, so many things out there that tell you do this and it'll solve your problems. Do this and that's the problem. But really what we're overlooking is the nutrition aspect, the mental health aspect, but also the actual medication that works for the individual instead of just the testing. And that's one thing that I always promote with you is, I've had clients whose testing looks completely normal, but their symptoms and what they're saying is not normal for them.
Yes.
And I go, I have the doctor, you need to go to her. And each time I've referred someone to you, they've come back with rave reviews. They're super happy with the way you not only guide them and educate them, but also the way you follow up care with them. They don't feel pushed. They don't feel like you're overselling. They feel like they got a great education, but they know that they can go back to you should things come up that have changed or that they want to rehash or anything like that. So I thought you would be a great guest for our podcast because we have so many women in this perimenopause, menopause, or postmenopause timeframe to dispel the myths and kind of get some of these questions that we commonly get answered. And also, one of the big things too is to share resources that you utilize, because a lot of women are finding a difficult time finding providers like you who look at the reality of the situation instead of just labs, prescribe, out the door. So that's one thing that we'll make sure to include for our listeners here is how to find someone like Dr. Lewis, because it's so important that you find a medical provider that you're comfortable with and that you feel like you've been heard. So when we're looking at Dr. Lewis's bio, she's been in clinical practice since 2003, originally practiced in the Pacific Northwest, and then moved down here to Phoenix, Arizona. She has a special focus on women's health, but she emphasizes nutrition and exercise and health maintenance and disease prevention and treatment. She's committed to the mental and physical health of women of all ages. I know. And she believes that her goal for health and wellness is a matter of progress, not perfection. So everything that you hear Christina and I preach on this podcast, every single episode. So she believes education and empowerment can help us take a proactive, preventative approach to the treatment of any condition. So
what I love too is, I just personally looked into the North American Menopause. Is it the Special Association? No, North American Menopause.
Branding change. It was a North American Menopause Society, but they've changed it to Menopause Society now.
I see.
Oh, interesting.
I've talked to Amanda about this, and I love to hear, whether we speak on the podcast or off about, just as a mental health therapist now, how people are connecting with this particular society, like practitioners, mental health therapists, all of the different entities to begin to kind of create this new area of focus, but I was glad to see that on your bio as well, because it's funny because, you test drive a new car and you see that car everywhere. I've test drove this North American Menopause Society and now I'm seeing it everywhere. So
that's good.
Yeah. So awesome. So, when it comes to menopause, and I'm sure you experience this, women do not understand that symptoms in their lives that they just put off as I'm getting older, right? Are actually symptoms of peri or postmenopause. So I'd love for you to start to just talk about the symptoms, and we can go into the ones that people are more familiar with and then the ones that maybe they're not as familiar with.
Yeah, well, and actually, if I could just for a second, even bring the lens back a little bit further in looking at the whole reproductive life cycle or lifespan for a female, really a lot of the issues that even can start as early as puberty are some things, or sometimes the symptoms that recur again and again during PMS, during perinatal, and then again during perimenopause. And specifically with, and I think we would probably find this as well with the physical symptoms, but specifically with the mental health symptoms, what the research tells us now is that there are some women that are just exquisitely sensitive to changes in their hormones. And that can be going from a high level to a low level, or from a low level back up to a high level. And so, you will see just in our normal menstrual cycle, just if anyone just Googles it, you'll just see that there are times when progesterone is high, and then there are times when progesterone is low. There's times when estrogen is high and times when estrogen is low. And at any point of that change in either of those hormones, that's a time where we can be having symptoms. And just like in, again, perimenstrually, or around your menstrual cycle, some women have like a ton of physical symptoms. Other women have a ton of mental symptoms. And then some have all of them. And that's what we see again in perimenopause as well.
Wow.
And so when you look at that and you kind of then think about the fact that estrogen really is the workhorse of hormone therapy in the way that we're talking about it today when we look at the perimenopausal phase or transition. Yes, progesterone levels decrease. Yes, testosterone levels decrease. But they happen at more of a consistent drop-off, if you will, than the estradiol, which, and I'm happy to share any of these visuals with you that you could share with your audience if you'd like.
I love that.
Yeah, but I put on my website, just because, again, picture saves 1,000 words, and this gets a little bit into the testing issue as well. But if you look at the course of like a 6-month time frame for a perimenopausal woman, and then you chart her estradiol levels, they will be all over the place. And this gets back to what you were saying, that like the testing just doesn't help, because I don't want to get all into that right now, but the testing is
we follow.
Okay, all right. Well, I will just say that, this is why testing doesn't help, because the one thing is that test is literally just a snapshot of time where you are right now. The problem is that level can look completely normal, and it also doesn't account for where are you on that, for lack of a better word, like the fluctuation. Are you at a time point where they captured it and you were going up? Are you on a time point where you were going down? And I know a lot of people too will say, oh, if you tested at the right time in the cycle. That is not true either, because in perimenopause, we have so much fluctuations. And also too, because even just in the normal menstrual cycle, like Amanda, you might hit your, progesterone peak at cycle day 21. I might hit, well, not menstruating anymore, but if I was, I might hit it at cycle day 20, so there can be so many. Well, I mean, that doesn't really make sense because it's not that different, but let's say 26. But anyway, everyone is very individual in, the realm of how they're producing their hormones anyway. And so that's why the hormones don't really help when you talk about testing. And why we see like this, like if you look up just Google menopausal symptoms, you'll see just laundry lists of everything literally from the top of your head, including like headaches, mental health, concentration issues, hair loss, all the way down to your feet, plantar fasciitis, and just like joint pain.
Like joint pain, yeah.
Dry heels. I mean, so there, and that's because there's estrogen receptors literally all over our body, in every system, in every tissue. And so, just like, when say you have the flu or the cold, you don't always have every single symptom that's there. I mean, sometimes you're unlucky and you do, but oftentimes you just have kind of the symptoms that you have, and it looks like the flu, and we call it the flu. And in some ways, perimenopause is a lot like that.
Yeah. The way I've personally just, and I any sort of information that I read, it is going to be a practitioner who is is someone like yourself that goes through either the UK or the North American Menopause Society or whatever they're called now. And the one gal that I follow, she really has bunched symptoms into more like 4 quadrants. So gut microbiome issues, inflammatory, cortisol or like weight issues. And then she has kind of the random, right? So the itchy ear, the frozen shoulder, the vertigo. I really like that she did that because you're right. It can be so overwhelming that, I mean, just list over list. I have unfortunately spent money on certifications that were supposed to be comprehensive in this area. And you feel like you almost walk away having more questions than answers, where I've learned to, like, with this particular practitioner, she was able to kind of put it in these bunches where, okay, if we have a bunch, not all of them, of course, but if you have a few of these symptoms here, we might want to look into gut microbiome. We might want to look into, inflammation in the body and so on. So that's been helpful for me. But, for you, for our listeners, like from a symptoms perspective, like what are the things that they should be looking at where they're not driving themselves crazy, where it's like, is this menopause? Is this menopause? Am I in perimenopause? Blah, 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 What are the things that our listeners can kind of take away and say, okay, maybe I do need to look at the fact that I keep waking up at 2 or 3 in the morning, and not going back to sleep.
And again, I know that you had the experience of, I don't know if you're sharing with the hysterectomy.
Oh yeah, I know. We talk about everything on here.
So I'll just
yes.
I know you had the experience with an early hysterectomy, and this is where we really do find where when I'm working with someone, and again, we kind of get back to this where there is no test to tell you when you're in. Well, I mean, obviously, if you've gone a full year since your final menstrual period, your estradiol levels will be low. They just will. So there's really no point to test then either. But say, for example, you're still menstruating, or like yourself, you don't have a uterus anymore, and you're like, where the heck am I? The biggest key is something happens all of a sudden for no other reason. Like that is oftentimes what we see. And so sometimes that in and of itself is one of the things, because I oftentimes talk about, this happens a lot of times in women's health too, but just generally, but you have like this bucket and you start throwing things in the bucket, and then the bucket is overflowing. You're like, okay, this is perimenopause. And that's where the key is. And that's where oftentimes I think that, and again, this is no shade on conventional medicine, but they have 15 minutes. Maybe they have a half hour with a new patient, but a lot of times it's very difficult to get through all of the possible symptoms. And of course, working with someone who's a specialist is going to know how to ask those questions that maybe you left off, or the things that maybe you might be embarrassed about talking about, especially when you're meeting someone the first time, like sexual health or vaginal dryness or urinary frequency and dribbling and things like that. So it's really going through like all of the symptoms and getting a good history on it, because literally if the typical woman I see is like usually crying, unfortunately, but they are so frustrated because they are, say, about 46 to 48. I mean, I do see a lot of people in that range, and they've already seen 2 to 3 providers. They were given antidepressants, anti-anxiety medications, pain relievers, and it's not necessarily that those things wouldn't work. And I know this is a little trite because a lot of people use this terminology all the time, but if you're trying to treat the cause and you're a 48-year-old woman and all of a sudden you have this cluster of symptoms like sleep problems, like hot flashes, like moodiness, like just like the worst PM, because those things can all happen too with PMS, but it's like instead of PMS being like 1 to 3 days before your period, and then you feel relief when your period comes, you either don't get relief when your period comes, or the symptoms start like so much earlier in the cycle, because they can start, those fluctuations start happening even before ovulation. So then you have this person who's like, you know what the change is? I used to have PMS and I have those symptoms, and now I have it all month long. It's not just, I can handle it when it was 3 days, but I cannot handle it when it's 3 weeks.
So I found it because I was thinking like, oh, maybe if someone is aware of their symptoms around their hormonal cycle leading up to the perimenopause period, we might be able to direct that a little bit more of like, is this abnormal or is this normal? And what you're saying is, yes, we can use those, I want to put regularities in quotes, but like those norms for that individual. as a baseline. Yeah, norms for the individual as a baseline. So if we know, like, okay, 3 to 5 days before my period, this is what usually happens, but you're saying it's the radical shift that is indicative of something bigger, as opposed to like, these symptoms are still there, and this is how I track them. There's not an abnormality, but a change in the norm. So that's interesting that you
significant enough change.
Yeah. And so, but I think again, it brings back to one of our core values for the three of us is we really have to be aware of our body and start listening to it instead of continually shut it down or ignore these things that are happening. Because if it doesn't matter for me, for example, for like the postpartum clients, like these things probably were occurring before we got pregnant. Now postpartum is just like the blow up of the symptoms.
Yeah.
And for y'all, in this like perimenopause to postmenopause stage, like if you're not aware of that, and when I'm trying to gather this information, I mean, we'll get it, but it would make it easier to be able to say, oh, okay, this is where we're probably at more so.
And that's where really the historical picture looks. And say, for example, people will have spent maybe, 10 years prior to having children on the birth control pill. And I even go back to that because even though they were a teen or a, 20-year-old person, or a person in their 20s, that they might say, you know what, people do say this. Now, some people say the reverse, but they'll say the best I ever felt was when I was on the birth control pill. No migraines, no mood swings. My periods were not all that bad. And now this is oftentimes what happens, not 100%, but people will have babies and then maybe, male partner gets a vasectomy and they don't need to worry about birth control anymore. And then they're like, what, sorry, it is actually a title of a book, but what fresh hell is this?
Yeah. Oh, we say all the cuss words here.
Yeah. So it's, but that's what happened. And again, too, getting back to, perinatal issues and postpartum is, a lot of people will look back and say, I just, haven't felt this bad since I was postpartum. And again, that is a time of a lot of.
Oh, interesting.
Yeah, because like when you're breastfeeding and then you stop, when you're waiting for your period to come back and then it starts coming back. Like there's all these opportunities for your, hormones to really take a hit in or in postpartum. And that's the same thing that happens in perinatal. What I was trying to point out here is also the connection. I know it's not a surprise. Women are having children later. I think we all see that just in our culture generally. And then I work with a lot of women who've had fertility issues. And so I am working a lot with people who maybe have had their babies in their late 30s and early 40s. But what we know is that perimenopausal symptoms can start 10 to 15 years before the final menstrual period. So if that's an average of 52 and you start backtracking, that's going to be in the mid 30s or late 30s when you could potentially have these symptoms starting. And so some people go right from like pregnancy, postpartum, their last postpartum, and now they're in perimenopause. And they're like, I have never felt. And so again, too, it's like putting that together because some women will never come back from that postpartum. Amanda, postpartum could be up to 3 years. So you might never really feel like you reset after that last child or, an older pregnancy. And then now you're looking at going right into perimenopause.
Wow. And that's going to be so difficult because like exactly what you're saying, it can be so easy of, the symptoms I did have now are really heightened. But if I've not felt well for the past 12 years and now I'm going into this, I thought after this last child, I would, bounce back, as they say, and I'm not, that can just be so confusing and defeating. And now we have small children, we're trying to raise them and all of the things. It is. And like you said, a lot of your clients are crying. I know when people come into our ecosystem, it's that same feeling of defeat, of failure, of what's wrong with me, what used to work isn't working anymore. So when we're talking about what used to work, so the, calories in versus calories out, the, going and doing 5 workouts every week and high intensity interval training or, running marathons, whatever that looks like. So the common struggle is what used to work isn't working. So could you just touch on that a bit of what might be happening there?
Yeah. And, this can really, I wanted to wrap around to one thing that you had said first, and this can go to this idea that things that used to work in the past don't work now. And for those women, I feel like the women who kind of really get it are the ones who really did have bad PMS. Now, I'm older than y'all. Like, I remember, like, really, it was just kind of like, PMS, just pull yourself up by your bootstraps, like, get over it. It's just PMS. Like, that's literally what doctors, teachers, parents, would tell girls, like, from time forever. So the problem really is like, first saying that we understand that these things can happen, like on a bell curve kind of continuum, where there's some people who don't have any symptoms at all. And literally there are those people too, that were like 90% of their friends are gaining weight in perimenopause. This other person doesn't have to change anything. And that's fine. This person doesn't have a hot flash. They don't have a mood swing. We're not talking about them. They can go live their life. At the top of the bell curve, and then on the other two, they are the ones that are having those like moderate to severe symptoms. And again, this is where, but you don't get to, 41. I don't know how, Amanda.
41.
I'm not going to, you're 41 too?
I'm not. She's 41. I'm 30. How am I? I'm 33.
Okay, you're a youngster. So 54, it's kind of one of those things that I still see patients who go see their PCP and their doctor's just like, you need to work on your diet and your nutrition and exercise and it'll all fall into place. But it just doesn't. I mean, how many women our age have already tried all those things? You don't go to the doctor like when you've gained like 2 pounds because you were on vacation or something, or maybe you fell off of the exercise. No, you try that back up again. And then if it's not working, you go back in, and you don't go in when it's 2 pounds, you go in when it's 10 or 15 pounds. And that is part of the issue. And so, and the same thing can happen with the mental health things. Like, I've had patients who are like, I really struggled with anxiety when I was in college, and I was on Prozac, sertraline, Lexapro, and you know what? It was fine. I was better, or I went and saw a therapist, and I had like 8 to 10 sessions, and I kind of check in with her, throughout when there's difficulties in my life, and that works. Nothing is working now. And you know what? What am I going to say to a therapist when I'm like watching a commercial and crying, or when my husband like forgets to do one thing I asked him and I start crying and screaming at him? Like, it's like those type of things. It's like, and that's the thing to really remember too with the mental health. Like I said, I feel like some people can kind of remember when they felt like that with PMS, like at a time where any rational thought was gone and you could not control what was coming out of your mouth or what the emotions were doing. And it's the same thing that you can extrapolate to hot flashes. It's like, it's hot. Oh, I'll turn up the air conditioning. You cannot turn up the air conditioning cool enough to truly, get rid of all hot flashes. You can't just like take a layer off and put a layer back on. And then the same thing with weight. It's like, it doesn't matter. You can read and look and see what everybody else does, and it really doesn't matter what they do, because first off, it's what's happening in your body, and we all react differently to diets. I saw influencer endocrinologist put today like what she eats like for 3. First off, it was all so beautiful, and one of the things was ceviche, and I'm like, who's cutting up ceviche for you? Because I don't have it. So I'm not sure who's doing that. But it's like, you can't, like, the idea that you could look and see like a day of my diet and a day of what I do for exercise, and that's going to work. I was just going to say too, it's like, I think we all probably know too, like some women who say, I'm going to lose weight and I'm going to run a marathon. And guess what? They end up gaining 10 pounds.
Yes.
And this gets back around. And this is what we see more after 40 and definitely in the 50s, where there are some people, again, because you can't make blanket statements, but there are some people, when they try to increase their exercise, increase the intensity, they are going to gain weight. And that's probably because of like cortisol spikes. The other thing is too, and Amanda, I'm sure you tell all your clients is that the more we exercise, we can rev up our appetite way more and end up eating, even if we think we're eating like what the machine, which the machine overestimates how many calories you probably burn anyway. Right. And the watch. Yep. But we end up overeating that. And, so that's the other problem is then you're like, I used to do endurance training, and it's like every time I did a long run, it's like I would have a hamburger, French fries, and a beer, and it's like fine and good, but like the elite marathoners, they have a snack size Snickers, and that's after a race, not after their long run. So it's like, of course, I'm not getting paid to run. I'm not doing that anymore anyway, but it's like we're all individuals. And so it's like what someone can get away with or what someone really enjoys. A lot of people don't enjoy like doing HIIT classes or going to climbing gyms or stuff like that. That's for that person who likes that. But usually we can find a way within the food that we like, like Mediterranean diet is really the only diet that is, I know you're a big fan. It's the only diet that has been shown to improve cardiovascular disease risk, metabolic syndrome and diabetes, cancer, brain risks for cognitive and mental and emotional, and then also for weight loss and maintenance. A lot of people forget that. And you can do that form of diet if you're a vegan, a vegetarian, carnivore. Even I guess you could do a keto too, but
Right. Well, and I think of, you're talking about the endocrinologist. I was reading a book that, she was talking about this like keto light because she did it and it worked for her.
Right. Yes.
And she created this protocol and, I had looked at it and I'm like, how is anyone going to do all of this? Like, this is so much. It's not sustainable for your average woman who literally struggles with getting enough colors in her diet, know, but at the same time, they are so desperate that they'll try anything. And because it worked for one person, they think it's going to work for them. And then on the flip side of this, I see a lot of influencers who are not in their menopause trend. Well, I can assume they're not based on age. I can't assume anything. That are giving advice. They have absolutely no education in this area. For me, I really focus on it from my specialty is mental health. As a therapist, I can get CEUs in cognitive behavioral therapy and menopause and the menopause transition and help women in that area of just, reconnecting with their bodies and recreating the relationship with their body and food. And then I educate myself with, as much as I can. But at the same time, I'm not going to sit there and be like, this is what you have to do, because number one, that's outside of the scope of my practice, other than the mental health side. And number two, it's all individualized. And that's what I don't think women understand. They're looking at influencers saying, oh, it worked for them, so I'm going to do it. That's not true. But also, I think oftentimes too, and I'd love to hear your input on this, they think HRT is going to make it all go away. Yeah. So there's this kind of, it's just so confusing while also being so defeating. It's like, you feel like you're going insane. So in regards to HRT, I'd love to talk about the reality of it. And obviously, like, again, you can't just put this blanket statement on it, but I think so many women think, oh, I'll go on HRT and all will be well.
Right.
Or I'll avoid HRT and I'll figure it out.
Because it's too dangerous for me to consider. Yeah, you're right. And again, I feel like the bell curve is just like life. But it's like the same. You're right. It's the same thing. There are these people who are like, I would never do HRT. I don't care how bad I feel, but you know what? I end up seeing them. So feeling that. It's just. I'm sorry. And like people will be like, well, why don't you tell people to use black cohosh? You know what? By the time I see someone, they've tried estrogen, they've tried black cohosh, they have tried all of the things. And I know, Amanda, I send these gals to you too, because that is the most frustrating point to be at, where you've done everything that the influencer has said and you still don't feel good. You're still not losing weight. And maybe you're gaining weight by what they said because they're a 22-year-old dude. So, that's one side of it. But the other side is with the hormone therapy, well, and to take one analogy I've really been like using with patients recently is like, we're kind of driving down like the freeway, right? And most freeways have 2 lanes. And yes, like, well, let's make it a 3-way. It was just on I-17 this morning. So on the one side, it's just your life. Like your life is going. And so you've got the things, you've got kids, you've got parents. As you get older, the kids, the parents, the nieces, nephews, whatever it is, you got the job, you've got keeping the house clean, you've got all of the things that you have to do. And then, of course, you have to be able to, get your 7 veggies a day and do all the stuff that the influencer is telling you. And then in the next lane, you've got your just aging, right? So, 100 years ago, our age at menopause was roughly the same. It was about 48. Now it's 52. Our life expectancy for women was 53. Now for women like my age who are just, in the last couple of years going through menopause, it's up into the 90s. And so that's another reason when people are just like, oh, you just have to get through it. It's okay. Oh, get through what? Like the next 40 years of my life?
Right. They don't realize it's the rest of your life. Like they're just like, oh, it's gone.
Yeah. And so that's that, middle aging is happening. And that's where that really comes up. Well, I would say they actually all overlap. But the other side is then the perimenopausal change. And a couple things to remember there is one, again, the symptoms can start 15 years prior, but that doesn't mean you necessarily are a candidate for or would feel better with HRT. Like there are other things, and that is oftentimes the time when we're doing some other things. And then, you brought up the early menopause the early hysterectomy. With that, the research is very interesting. When I was first in school, I used to do rotations with OBGYNs that would tell people, and again, we didn't know because we didn't do the research, but they used to tell people, we're just taking your uterus. This does not impact your hormone production. Guess what?
That's exactly what they said. Yes.
Oh, don't
Preach, girl. I know what you're about to say.
In the early 90s. I hope they aren't still saying that, but we have the studies now. There is blood and nerve flow damage to the ovaries. It doesn't matter how good your surgeon is. It's just a mess in there. And so they are cutting things. Blood, it happens because they're cutting blood flow. So again, some of that does get repaired and get fixed, but there is blood and nerve flow damage. So you are likely to go through an earlier menopause than you otherwise would. We don't know what that alternate universe looks like of when that would have been. And the other thing is that you can have more significant symptoms as well after a hysterectomy. They've shown that even if the ovaries remain intact.
Yeah, I had heard Dr. Dr. Mary Claire Haver say it's like you're basically speeding it up 4 years is what the research has shown. And Dr. Leigh Lewis, this is the first time I heard this in the past 3 months. I had a hysterectomy when I was 35. Yeah. And I'm 41. And it was like, oh no, we'll just keep your ovaries. It's fine. The other funny thing that happened is, I think I've talked about it on the podcast. No one prepared me for the fact that I was also losing my IUD.
Oh yeah.
I was like, why am I going crazy? Like, why do I want to kill my husband? Like, what is happening right now?
Well, that's another, fallacy that, again, in the early 90s, I was there when the progesterone IUD came out. I loved it. I thought for a time I would leave my job and become a rep for them because I used it for years of my reproductive life. Loved it. And we used to tell women that too, that it's only local, only working in the uterus. And now all these studies have come out and they said some people can have some mood benefits from it. Other women feel worse. They feel terribly depressed. You can have pelvic pain that's contributed from that, even if it's in the right spot. They're like, oh, ultrasound, it's in the right spot. That's not your pelvic pain. Oh, it can be. You can get acne, you can get hair growth, you can have libido issues. So so if you think of those 3 lanes that are going on for you, that it would be ridiculous to think that if we just fixed one of those lanes, it would be like, if I just quit my job, everything would be perfect. No, because you still got the kids, you still got the parents that, you have to deal with. And with aging, well, we can't stop that. There's nothing. And this is another pet peeve of mine, is calling HRT, MHT anti-aging or longevity medicine. It is not. It's not that. And then you have the MHT here. So there's in that final lane. And
can I pause you? What is MHT?
Oh, sorry. Menopausal hormone therapy. It's kind of just a new HRT because they don't want to really... Because again, there are those women all the way, I guess I was on the side of the bell curve, who have no symptoms. And so we don't want to really think of it like it's a deficiency, because not all women really need to be on it. Again, I'm not seeing a lot of them, but I meet people like that all the time. And again, too, sometimes a lot of people don't talk to their moms about it, but some have come in and they're like, oh, my mom said it's no big deal. She totally felt fine. Well, that was good for her. But it's, of course, everyone has their own different experience. So menopausal hormone therapy is seen as a treatment for the menopause symptoms. And that's really what we have FDA approval for. It also, and again, when we talk about prevention, is it going to prevent cardiovascular disease? No. Is it going to prevent dementia? No. You know what can prevent? Osteoporosis. We know that. This gets into very specific terminology medicine uses in terms of what's primary prevention. You can only call something prevention if you're really talking in the terms of primary prevention, that you give it and it prevents this one thing from happening. Right now, we do not have research to say that people who are used, like me, my age, 54, I have a patch, progesterone pill, and testosterone. We have no evidence to say that any of that is going to be a primary prevention for cognitive issues, cardiovascular disease, and metabolic issues. But we do know that it can improve some of the numbers, like lipids. We know that blood sugar can be better. And so that is another thing I really see people saying, that like, oh, MHT is a panacea for all of your problems and is going to prevent every chronic disease. That is not the case. Again, with that, I think that was getting back to what your question was. You cannot expect menopausal hormone therapy. I'm trying to think of a good example of what I see, because, and this is back to something Amanda said earlier and reminded me, that you can have like a problem that you have. So I'll, again, just say I have joint pain, right? So I have rheumatoid arthritis. I have a level of joint pain. Now, I did get more joint pain when I was going through the menopausal transition, and I used the estrogen patch, and it helped with some of that, but it's not going to cure my rheumatoid arthritis. Another thing is, like, by the age of 50, how many percent, I don't know off the top of my head, but a lot of people have osteoarthritis. And estrogen is not going to fix that joint pain. That is damage that has happened over your life, and it's not going to be better. What the estrogen helps is the inflammation that is there, that comes with having low estrogen levels, that can inflame your joints. So oftentimes, like, we can expect maybe 10, or not 10, that's pretty low, but like maybe like 50 to 75% better, but we're probably not going to get 100% better, because life, aging, and there's hormone changes there, and we address that when we can.
Yeah, and that's where, a program like ours comes in, because I've created the mindset method, which is to help with the life side of things, of, helping women during this transition it's not just women and men going through the menopausal transition, but just helping women through the struggles in their lives, and being able to understand like their self-worth rules, the way that their boundary system or lack thereof, which if we don't have that and we're going down that life side of the highway, we're literally just like hitting every car at the expense of ourselves, just to make sure that we take care of everyone else. So we have that ability, but then also, you had talked about the cardiovascular, the cognitive, also being able to incorporate things like a anti-inflammatory diet and have enough education in that area to support someone. Also being able to incorporate things like strength training, which have shown to reduce all-cause mortality and help with your mood, your mental health, and so on. So do you offer that as well, the lifestyle changes as well, or do you focus more on one side? Like, what does that look like for you?
Yeah, I mean, well, first off, I would say 75% of my patients get therapy referrals. I am a huge believer in therapy. And, quite honestly, I was really encouraged when I was working more with like the full lifespan. Almost all of my perinatal patients were getting them because they already were struggling with fertility. And, that has been linked to increased risk of anxiety and depression and relationship problems. And so I'm like, go there, get help now. And you know what? You're going to have that person in your back pocket for, when the kid comes and you're in postpartum, right? Should you get pregnant, you're going to want to have contact with someone possibly in postpartum. If you don't get pregnant, what is that going to look like, right? And I did talk to a lot of my patients about that and was trying to set them up for the fact that not everybody gets pregnant. Not everyone has just tons of money just to be doing this over and over again forever. And there are some people who come on the other side and don't have it. So I really got into doing that very early in my career. And now it's like I said, or I didn't say, but I wanted to say that so many people focus on like the menstrual changes with perimenopause and the hot flashes. But you know what? A lot of my patients don't have either of those things, but it's that mental health component. Their anxiety can be crippling. It doesn't have to be this bad, remember, and you just shouldn't wait for it to be this bad before you reach out. But it can be like panic attacks where I have patients that can't drive on the freeway anymore. They don't do anything socially anymore because their like social anxiety has come up out of nowhere. People who used to go out all the time and do all these things. And then the depression, just crying for no reason, terrible motivation. And that's, again, one of the things you throw in the bucket when I have a patient who comes in and says, I just don't feel like this is not me. This is not me with my husband. This is not me with my kids. I don't want to be this person. And, that, again, that's not on any menopause list to check off. But to me, that is really something. And so therapy is always that. I think that's so important because then the other thing that happens too is like, then, I'm always like, again, going back to like talking to the fertility patient, is then if you do get pregnant too, like that kid's going to be a teenager. I'm sorry. Like who is handling that these days without having like a little therapy for yourself? And then older, and then it's like you're dealing with your parents, and there's always a need to have someone to check in with, I think. So I'm just like, hey, find someone to have in your life for those speed bumps. Again, I'm kind of really coming up with a good analogy here.
I love it, which is funny because we use this roads analogy when we're talking about like neuroplasticity and recreating new neural pathways in your brain. So yes, we love this.
So I like that. And then, like I said, too, Amanda, I send people to Amanda because I do think, again, you don't get to 54 years old without thinking like cardio. I mean, that's how I was brought up. I was brought up in the 90s. Like if you wanted to lose weight, you just, whatever we were doing, the stair stepper, and I come from an endurance background. So, you wanted to cut some pounds, you just ran more, rode your bike more, swam more, you could get that done. But the other thing is too, and this might be maybe more of a conversation for you guys to have on your podcast at another time, but there's that whole, and I can give you some information if you want, but I think Amanda already knows about this too, is metabolic adaptation. That whole process really hits women in their 40s and 50s. Again, you might have been able to go, and have like, just smoke, or, I mean, I hear all sorts of things, but smoke and lose weight, or, not have dinner and drink those calories, like with alcohol. None of those things work in the 40s and the 50s anymore. It's not just about calories in, calories out. That matters, but it also is, like say, for example, alcohol, which we haven't talked about. Amanda knows that's a big hot spot for me. But, and again, it comes back to a mental health thing, is that I still see women, when I say they're doing all the things, most women are, but one thing that they're still maybe doing that they could definitely change, it would improve every menopausal symptom, from joint pain to poor sleep to poor mood to relationship issues and hot flashes and wrinkles and, just all of the things, and weight for sure, is the alcohol. I mean, alcohol is not just calories. It messes with your hormones. It increases your appetite the next day, or it's kind of like that gateway drug for eating. It's like you have a glass of wine. It's like, I'll have some chocolate covered almonds. I'll have another glass of wine. I'll have some cheese and crackers. Oh, that's me. But, and so that's where too, when you say like, I have patients who are on hormone replacement, if they're still drinking 2 glasses of wine every night, they're not going to lose the weight. They're not going to sleep better. Their mood's not going to be as good as it could. So it's like all of those things, like really, it does make a difference.
Absolutely. Well, and Amanda, go ahead, Amanda.
So, to circle back, but to incorporate this a little bit. So we're talking about like diet and lifestyle changes, or modifications, or considerations rather. And you had brought up birth control. We talked about MHT and HRT. When women are going through different transitions throughout their life, maybe more stress, less stress, or maybe their symptoms are waxing and waning or something, when you're prescribing the HRT or MHT, are you changing that dose over time too to match like maybe their activity level or their nutrition, or it's kind of compartmentalized? I don't know if I'm asking that right.
Well, but you're asking a good question. And I would say, I don't know if this is exactly what you're saying, but there are, say that there's an early hysterectomy. As soon as that woman, because she's not bleeding, as soon as she starts having any type of mental, emotional symptoms, hot flashes, sleep problems, we can try the estrogen then. Because the biggest risk you run with either going too high with estrogen or adding it too early is increasing bleeding. So for those guys, I'm always like,
good. Let's go.
There's also,
I will be in your office tomorrow.
it's probably too much to get into for this, but actually it's like my favorite group of women to work with, because you don't even really have to talk about the risks too, because unless it's like very small category of women who maybe have had breast cancer in the past or something, a crazy family history or something like that, actually the women who only use estrogen have been shown, even after age 65, to have no increased risk for anything. So it's a combination of the estrogen, progesterone together. But so for someone who's not bleeding, it's like, well, or say who has an IUD and is not bleeding, the progesterone IUD, we can add that estrogen in at, you know, at a pretty young age if she's already having what seems to be perimenopausal perimenopausal symptoms. And I always feel like, why not let's just start there? Because we know, you know what we know is we know she doesn't have an SSRI deficiency. And if you're truly having hot flashes and joint pain and mood issues and anxiety and sleep problems, it's like, well, an SSRI is not going to help all those things anyway. So I'm always saying, like, there are very few women that don't deserve a 3-month trial on hormones. And I'm like, let's see if it works first, right? Because it might not work, you know, especially when you're in like that young age and you're like, I don't know, is this just going to be a very long perimenopause for me or what? But so that would be one thing. The other thing is then for those gals who are starting younger, we do sometimes increase the dose over time because her natural estrogen level is decreasing over time. The other thing is too, and this is why I hate, again, Amanda, sorry, I know you know this. I hate pellets because we never want like this super physiologic or really high level of estrogen and or testosterone. And pellets will do that 100%. It's not safe. You might have side effects from it. And if you do, you cannot get that pellet out. Like, I think that's missing in a lot of people getting pellets. Because I see them, and like, no one told me I couldn't get it out. And it might take up to a year to get these, you know, the hormones to truly get out of me. What MHT is doing is it's lifting the bottom. So you're kind of, you know,
microdosing almost.
In perimenopause, you're hitting the bottom. You're hitting the basement of the bottom of the barrel of your estrogen level at times. As you get to menopause, then you are kind of in the basement. I don't know what's going on. All we're trying to do with estrogen therapy is to bring the basement up to, say, the mezzanine level. And so you don't have those really low levels. And also when, again, with that fluctuation, you're not going from super high levels down to the basement. You're kind of going down a little bit. And then we're giving you a little bit of a safety net there or cushion so that, you know, regardless of what your body's doing, we're not trying to do like what's in the birth control pill, which is put your ovaries to sleep. You're not going to have steady state hormones from the outside, but we're just trying to bring the level of estrogen up so you don't drop, you know, bottom out and feel so.
Love that.
So sometimes we are increasing it, but now in terms of like changing it because of, I would say also if there's a change in weight, we oftentimes are changing estrogen levels. And then some people even, you know, again, they could be in menopause and they'll still have this time. Like, I feel like I'm in it right now where, because we know, you know, we live in Arizona, so heat is a trigger for hot flashes. I probably this week, and you know, it's going to be terrible this next week. But I've already had like 5 people ask me if they could go up on their estrogen dose. And I just think it's just like so hot right now. So so there are going to be those things that happen where you feel like you need a bit more, or stress is higher and you're not sleeping. And, you know, maybe that would help with some of the anxiety and depression and whatnot. But generally, I don't change based on like activity level. We only have 5 dosing options for the estradiol pill, and it's pretty easy. I mean, 99% of my patients are on the middle of the road, 0.05 milligram patch. It works really well for everyone. The younger gals, sometimes I'll start them lower, or people, again, I believe women when they tell me they're sensitive, we start low and we increase slowly over time. I love that idea. Need be, because actually some people do really great on that lowest dose.
No, and that's something I have talked to clients about, whether it's, you know, hormone or even this, you know, the what's it called? Wegovy, semaglutide. You know, we don't have a lot of clients on that, but you know, just looking at like, why would you start at this high dose of, 0.25 or whatever it is, you don't know how that's going to affect your body. And again, Amanda and I listen to a lot of podcasts and read a lot about, microdosing and that the information around hormones of starting low and kind of bringing it up. And I think that's important for people to understand is, again, it's all individualized and it's not going to work right. You may not have relief in your symptoms right away. And to keep track of your symptoms, even while on HRT, so that when you go back to your practitioner, you can be able to say, hey, this has improved. I'm still feeling this. And I think as a practitioner, then we can look at obviously the changes that you talked about, but also lifestyle, because you said something really interesting that I want to emphasize. When stress gets higher in her life, we might make changes to her hormones. Mm-hmm. So I want people to also look at that on the flip side, that if we're not managing our stress, right, or we have this big thing that happens, right, and like we need to pay attention to that still, because again, women have just gone through life, whatever, I have this toxic resilience and I have the, as I call it, the hustle culture, and I just go through life kind of pretending like it's not bothering me. Oh, I'm having these symptoms, I'll just get on HRT and things will be fine. And then shit hits the fan and we still feel like shit. And so there's this part of it too that I really want to emphasize of, we've got to do the work. We've got to try to manage their stress more, because I guess at a certain point, if their stress is still going high and you get to the fifth layer of HRT, then where do they go? Right.
Well, and to your point about dosing, it's like, and we didn't really talk about this, but there was that study that came out in the, I graduated 2003. The study came out in 2002. I've always been a menopause specialist. And it's like, what were we supposed to do? Because all that scary, information came out that was then found to be, very misinformed in terms of how the media spun that and took the data. And now looking back, it looks very different. We use very different hormones like the estradiol patch and progesterone, both bioidentical, both through your insurance. Those were they were actually available when that study went on, but they didn't choose to use those in the study. We will never get another bite at that apple again to repeat that study. But what do we know in medicine? The lowest dose that we need to control the symptoms is going to have the less risk. And like we said, like maybe gals who only need estradiol or who only need vaginal estradiol, which, takes care of a lot of things below the belt, that is no risk of that either, like in terms of long-term use. But for the gals like me and, most people who still have a uterus, you have to use the estrogen and progesterone together. And when you push the dose in that, theoretically, we're increasing the risks, like of breast cancer. So, if you can, like this goes to your point, if you can manage the stress through therapy, if you can manage just your way through getting some good advice on what you should do and not just doing way too much of the wrong thing for exercise. Yes.
Or food restriction, because, in menopause, that is not what you want to do, is crazy food restriction.
Second highest peak, except for like teens and 20s of eating disorders for sure. Yes.
I didn't even know that.
Yeah, because what's happening? You have this weight gain that's happening, or body composition changes, and you feel like nothing you're doing is working, and you hear calories in, calories out. So what are you going to do? You're going to restrict. Sure. But yeah, so that, you need to have all those things working together and really still trying with the other tools in your toolbox so that you don't want to just be bumping it up and up and up for no reason.
Oh, I love that. That is actually really interesting, because I do see this, especially in this particular generation of women going through menopause. And I adhere that to the fact that they're also the generation that grew up on the 1,200 calorie diet, right?
Wheat thins. Yes.
Yeah, wheat thins, SnackWells. Remember the SnackWell cookies?
Yeah.
Like I have a client right now who is hypothyroid. She has a hypothyroid. She has her A1Cs are a bit high, and these, I'm trying to explain to her, like, we need to eat more. You keep telling me, I know this is how I lost weight before, intermittent fasting and keto. And I'm like, obviously it's not serving you anymore. Like, can we just agree on that? Like, I'm not going to talk anyone out of anything that worked before. I'm just going to say it's not serving you now. Right. And she still has that mindset of this like 800, 900 calorie range that's freaking her body out. I'm slowly getting her up. It's been tough, but very challenging, but we're getting there. But even that, like as someone who's worked in the eating disorder industry, like in intensive outpatient and outpatient, I mean, she is now, her body is not responding in the way that I've seen with people with anorexia, but like a lot of her behaviors align with that for sure. But coming back to just the generational piece of it too is, you know, generationally, like I see that more in this for these particular clients. And then they're also trying the other things they've heard, the intermittent fasting, the keto. And, you know, in my experience, that's just also like prolonged fasting, being in a calorie restrictive state. These are things that are only causing them to eat less, still not see the results that they want. And from my understanding, putting even more stress on your body. So I'm curious if you can just
so that's a great point. And again, it kind of goes back a little bit to and you had mentioned about like these diets that people are doing because of like kind of the orthorexia. I mean, being a naturopath, again, I have a selection bias. I'm usually undoing people's restrictions. And again, working with a nutritionist, I know Amanda knows, Liz Brinkman, who I think is so good about that, getting people off of like being scared of food, just regular food. Like you can't eat anything anymore. So that's another referral that I make a lot. But there's a couple things about what you said. One, the information about I like to call it time restricted feeding, because I really think that with the research, like if you're fasting, it's like more than 24 hours is like a fast. And then we tell people if they really want to try that, I try to have people do like, I call it the 70s fast, like how we used to live in the 70s. Like you ate dinner by 6 and then you got up in the morning, and when you were hungry, you ate again. You just that is kind of a big fast, but it's a natural fast. And so you're not like, again, having excess drink calories or snacky calories before bed. And then you're waking up, and as you again, if you're an early morning exerciser and you feel better if you eat then before your exercise. If you actually feel better exercising first and then eating, fine, eat then. But to try to listen, like more of that intuitive eating. The other thing, and the reason I bring that up is because most of the research says that you actually don't get any more benefit than that, but aside from just regular calorie restriction. So then you get back to also the problem of women, especially middle-aged women, not eating enough to support all the activity they're trying to do, because all these people are telling them you should, like, how can you like actually get muscles from stressing your body if you don't eat enough protein? And then also with the carbohydrates too. Women specifically, and again, it's 20 years of experience. I've not really seen a study on it, but I don't think anyone's going to do it. But I hear from patients all the time that when they try keto, they get very moody, their energy is zapped, and you can't exercise like that either. And then there's also like maybe I need a snack, brain fog, that a lot of it, if you're not having that fuel, I mean, carbohydrates are quick fuel for the body. And if you're not giving yourself that throughout the day, you have to, you can get into a situation, again, Amanda, you could probably talk a lot more about this, but where you are breaking down muscle to try to feed your body. And that's not, and again, sometimes your body will break down muscle before it breaks down fat. And that's not what we're looking for. So it's why it's so important to work with someone who can really guide you on those things. Because it truly is about a balanced diet. It's like, I always tell people too, because the other side that I see, I think is really, not helping, again, the middle-aged women. Maybe these things work for 20-year-olds. I don't know. But it's like, this idea that you have to hit 200 grams of protein a day. I mean, I just see people like having a huge protein shake before bed. And I'm like, what? And then losing weight because they're over-consuming calories to try to hit these artificial, daily goals.
Numbers.
It's like, it makes no sense.
Yeah, everything we do. So everyone that works in the Mindset of Matter are also personal trainer and certified nutrition coaches. So we all have backgrounds in that area because we want to not only help people with the like mental shifts, but also give them sustainable health habits. And everything is customizable to our clients. But when it gets really, I get more specific in like quality of food with my particular age group that I work with, which is usually 40 and over, because prior to this, they were able to drink the protein shakes and eat the protein bars and their body was fine. They weren't ravenous afterwards. Now in 40, they're like, I'm hungry all the time. So we'll look, and Amanda does this too with her clients. We just look at their food intake. And I'm like, well, of course you're hungry. Your body went through that food like this and your blood sugar is a mess because of it. So let's maybe try some whole foods and delay gastric emptying, but everything we do is so customizable for each person, including their exercise. And our whole goal is to find what they can do. Because at the end of the day, where social media is really, one of the main reasons it's very hurtful for this particular population is at the end of the day, what you can be consistent with is what's going to be important. Mm-hmm. And while we guide clients to say, yes, we want to have an aspect of resistance training in your programming for all of these reasons, right? And we list them off and educate them on it. We want to have a balanced diet where you're getting the macro and micronutrients, the vitamins and minerals that you need, hopefully through food. Because that's the other thing is people are like, I'll just take supplement. It's like, well, why? You don't have to. Like you can have 2 to 3, servings of fatty fish per week, which is delicious, right? Then, have this whole slew of different supplements. So we're able to create that space. So on that subject, talk to me about your annoyance with supplement companies.
Well, it's a two-pronged approach, I'll say, is definitely the supplement companies, because I'm constantly getting, and this really is the truth. And it comes from, too, the standpoint of the pellet companies as well. I'm constantly getting emails for them trying to court me to incorporate these things into my practice as a revenue stream. And I think it's so important for women, especially just because, again, if you look at any of those time frames, it's like between PMS and period problems and PCOS and endometriosis and pregnancy and then now perimenopause. There's all these supplements directed to you with like all these huge promises. And the problem is very few of them are going to work. And the issue also is like what I'm seeing with the companies now is they're getting you into the subscription thing. So then you are already buying like 90 days worth. I mean, quite honestly, I guess if you're really trying to do something with your cycle, it's probably good to give it a 90-day trial. But like if you have a hot flash, can take the patch for like, I have people text me all the time and they're like, oh my gosh, this is a placebo because it worked within 3 days and I'm sleeping and I have no hot flashes. And I'm like, no, it's because it works. And they're like, well, but I'm like, if it was a placebo, all the black cohosh, all the estrogen, all the turmeric, all the collagen and creatine, whatever that you're taking, all those things would have helped, and so that's the biggest thing is like, I'm usually trying to taper people off of supplements for a lot of it. And how I usually tell them is just like, let it run out over time, because again, people have a lot of supplements, and then you'll see if you feel the difference or notice the difference or not. Oftentimes when we get something like, say, if it is a perimenopausal woman with perimenopausal problems, and we get her on the right hormone therapy, she finds she doesn't need those things, and then again, she came to see me because they weren't working. So they might be working for some people out there, but so that's a big problem that I see. And then the other side is the provider selling the supplements, and they're doing that at they're getting it at cost. They're doing it as a markup as much as 50%, and then. Again, they're getting that profit, and I worked at the first clinic I worked at out of school. The clinic leader, the head doctor, told me that I could make more money if I sold more supplements. And I was just like, that's not how I practice, but okay, thanks. So if we're talking,
we just talked about this. Yeah.
Yes. It totally drives me crazy. Yes. Cause I know it's in your world too, both mental health and also physical training. Yes. Personal training.
Yeah.
So definitely, and then nutrition. I mean, there's all sorts. Like nobody, and again, it's MDs, it's DOs, it's nurse practitioners. Nobody is immune from this. But I will say, yes, naturopaths, chiropractors, oftentimes are taking advantage.
We've seen everything in our program. We've seen even women who like, what is it? Parasite cleansing and
Oh,
all of this other stuff. And then we get the list of, because I want to make sure I have a list of everything they're taking. And it's this paragraph of all of these things. And I'm just like, I don't ask because it's not my business, but I'm like, how much did you spend on this? Like, this seems, and also
well, and it's extremely expensive.
yeah. And wait, how many times do I have to take this too? And then I will check in on them months and months later. Cause normally because it was so expensive, they have to leave our program, unfortunately, and I'm like, and then we could have had, sorry, real quick. We could have had that 4 months to focus on consistency with the food, the diet, the mental health, and you're probably going to feel a lot better than the 4 months of you just shoving pills down your throat. So,
and that's where I also think it's ridiculous, is because, and I oftentimes joke with women because again, who I'm seeing, I'm like, don't stop spending money on that and go get a nice dinner. Amanda knows I'm a big foodie.
I love that.
A new pair of shoes. Like, why? This is just like a waste of money. And it's the same thing when people are overspending for hormones, not using the insurance that they already paid for to get it. And then, too, a lot of the doctors who recommend things, and maybe they seem like really normal things that they're selling, like calcium or collagen powder and things like that. Like, if you want to take that, and calcium is one that I oftentimes recommend, magnesium is oftentimes another thing that's really good for people to take. So there are some supplements that if people are trying to correct a deficiency of B12 or iron or folate, those type of things. But you know what? You can always find them cheaper on Amazon. And for vitamins, I'm sorry, there is not any fancy special vitamin you need to have. Now, for herbs, and again, I sometimes do use herbs like for sleep. I really like valerian if someone needs a little help. But you can get that on Amazon too. And it is good to get a good company recommendation, but you can get it from that company. It used to be where people would be like, oh, you might get a fake. I'm sorry, nobody is spending all the time to make a valerian capsule. And it's like the actual company is selling it on Amazon. So
we have full script through the company.
Yes.
To get any supplements. We use full script.
And that's the other thing that I always share with anyone I work with. Like, is if you have a professional license, get your own account and get that stuff yourself for yourself and your family. Like, you don't have to pay someone else so that they can make money and you end up paying double. That makes no sense.
No.
Question. So
I love this.
Between like the MD, your field, naturopath, and the supplements and the HRT, and how do you stay up to date with like all of this research and this information? Like, how do you filter through it as a provider, and then how do you suggest like your patients filter through it as well, if at all? Yeah,
I mean. Well, so this, I know you wanted to end here, I think, too, with the resources. So you're right, the Menopause Society and the International Menopause Society, and you brought up the British Menopause Society. There's like 4 good ones. So, and they're all in English, luckily, but I'm sure
Australian too, right?
Is Australian, yes, is the 4th one. All of them, you can get very good information.
Okay.
You can oftentimes sign up for newsletters from them and get some good information too. Along the mental health, I've really been suggesting a lot of people look into the International Association of Perimenstrual Disorders. It's IAPMD, because the like I said, the mental health component of it can be so significant and so much like PMS. And they have actually a really great article on there that you can share with your partner who might not understand what's going on. And also PMS and PMDD can get a lot worse in perimenopause. So it's like you're still, even though I actually just did a really good training with them where they really did incorporate a lot of the changes with perimenopause. So it is like a hormone change group that really focuses on good content for mental health and how the hormones interact with that mental health. And then finally is the it's very long, International Society for the Study of Women's Sexual Health, ISWISH. They have a patient website that's called, might have to look this up. Prosela, I think there's an S in it. Prosela, Proslea. There's a Y too. Sorry, it's on there. But it's really
we'll put it in the show notes.
Yeah, you can do and then you can do member searches for providers who belong to IAPMD or the Menopause Society International. I don't know. I mean, I belong to International Society, Menopause Society. I don't know how many other American people do, but and then ISWISH. So you can search for providers who have that special training. There's a lot of crossover between the Menopause Society and ISWISH as well, just because like women's sexual health and perimenopause kind of go together too.
Right. Well, and there's only so much research, unfortunately.
Yes, well, that's true. But the other thing I do, which, I'm lucky, Amanda knows that my husband works at the VA. So I have like all this access to like every article that's been written. So not behind a paywall. So what I do is when the new ones that are really like groundbreaking for menopause, which a number of them have come out even just this year, is I get them and post them without the paywall on my website. So you can always check there. And so like there's like, the WHI, like that scary study revisited. So like the experts in the menopause field have written an article looking at all the misinformation that was there and what we've learned since then. So you can get that. And I try to, put podcasts on there too that talk about this and other like patient support links as well.
I love it. If you could please share where our listeners can follow you, maybe your website or social media as well.
So Instagram is Dr._Leigh_Lewis, and I'm on Threads, but I'm a little snarkier there. And then,
so our listeners will also follow you there because they love us and we're snarky too.
We're very snarky.
And then the website is www.arcadiawomenswellness.com.
Love that. No, awesome. Well, thank you so much. I think that we could probably talk about this for hours and hours and hours, but at least this gives people an understanding that this is something to pay attention to, even if you're not there yet. Pay attention to your symptoms around your cycle and what it feels like in your body, both mentally and physically, to pay attention when there's big shifts in those symptoms and or shifts in general, and that this process is all individualized. So working with a person like yourself who specializes in menopause, because and we didn't even talk about this, people will just go to an OBGYN and have misinformation thrown their way, which, we can have another conversation about that.
Any doctor and have misinformation thrown their way. So,
Correct. But they assume that OBGYN means hormone replacement specialist. And that's not the case.
That's true. And getting back to research, one of the articles that I have on my website that was through the New York Times, it said they did a study of OBGYNs that just graduated, and only 20% of them thought they had any education in hormones enough to prescribe for menopause. And so, that's the other thing. If you think of the umbrella of OBGYN, it's just way too big. And you're starting to see these people branching out, like, becoming gyne surgeons. Like they don't deliver babies at all. All my endometriosis patients, I send to a gyne surgeon. I don't want them seeing someone who's delivering babies, 5 days a week and doing one surgery a week or something like that. So you're seeing a lot more of that specialization under the OBGYN, and hopefully that'll keep happening.
Yeah. And on like my side of things on the perinatal, they're talking about that. Like the podcast and the information that I get is they're saying it's way too broad for OBGYN.
Yes.
Like just because you see her for the UTI doesn't mean she needs to be delivering your baby.
Right. Yes.
And let's start breaking it up a little bit more. But again, that takes a whole like cultural shift within the, atmosphere. So I hope that happens, especially considering how our worlds intersect so much, that people can recognize the importance of people like you who have that higher level of education for the specialty care, and would be willing to refer. Because that's one thing too that I see is this beauty of referring creates a better approach for the patient and for patient-centered. Right. That's really the goal, right? But when you're keeping everything in-house, you only have so much information that you can withhold.
That's another thing that comes up on my red flags list all the time. And I do think that naturopaths and functional medicine doctors are the worst, and NPs, some of them are the worst offenders, because they'll say, I treat cancer, I treat leaky gut, I treat autism, I treat autoimmune diseases, I treat hormones. I also will give you Botox and do a,
semaglutide
thing. Yes, and
of course. I mean, who isn't? That's so funny. It's hilarious.
Specialist in everything. That's just not
right. Well, and even in the Mindset of Matter, like, we specialize in recreating your relationship with your body and foods through the inside out, because that is our focus. We do not do general macros. We do not do general training. Can we? Yes, but there's billions of people out there that will gladly take that from you. What we do is what we do. That is our lane. We do it differently. Everyone has to go through our method if they're going to be in our program, because we know that most of the time it's what's going on in here that affects you out here. So I love it. Awesome. Well, if you guys like this information, please give Dr. Leigh Lewis a follow. Check out her website and all of the information she provides. Can they sign up for like a newsletter or anything through your website?
Her newsletter is great.
Oh yeah, I'm on it. I didn't know this. Yeah, I love it.
People work with you out of state, like if they live in California.
Sometimes there are some states, and this is another kind of a little caveat tip, is that even those like menopause companies that do prescribe, that's a great way to get started on estrogen and progesterone, but they cannot do testosterone across state lines. So my alloy and those, I can't even think of the other ones, but the hormone companies, MIDI, they can get you started, and that's great, but they won't be able to take care of any controlled substances like testosterone. So it's the same thing for me. I can oftentimes work with people in California and Colorado, and up kind of the whole West Coast, and work with the estrogen and progesterone. But testosterone, you have to see someone in your city, or in your state. And that's why those organizations like ISWISH are so great, because you can do a provider search, find someone in your area.
Okay.
I have a client for you in the Pacific Northwest. So,
that's where I'm from.
Yes. So awesome. If you like us, our information, you give us a follow on Mindset of Matter Coaching or fitbyamanda.az on Instagram. If you'd like to see the recording of this on YouTube, it's at The Mindset of Matter. Please give us a subscribe there. If you're listening on Apple Podcasts or Spotify, we love a follow and or a 5-star rating and review. And if you have not figured this out through this entire conversation, we want to leave you with one last message, and it's this:
what you say in the mind,
you see in the mirror. Bye-bye.